Greetings from AD Hospital. We started this hospital in 2010 April. In this 13 years, we are happy and we are satisfied in treating our patients. I started this to bring all advanced treatment to all our patients. We are having inpatient, we are having surgeries for diabetic foot, for surgeries for thyroid, surgeries in thyroid carcinomas or multinodular goiters. We do thyroid scans ourselves, and we do ultrasound scan guided FNACs, precise, and taking out samples for FNAC if we got doubt in thyroid nodule.
Hospital in Kukatpalli, Hyderabad, we take pride in our well-equipped laboratory. With Macura I1000 and Roche hormone analyzers, we do a precise analysis of various hormones like testosterone, prolactin, FSH and LH. Our lab operates efficiently with the support of 2 skilled lab technicians and 4 phlebotomists who collect blood samples both within the hospital and in the comfort of patients' homes. We are committed to provide fast results with reports being generated within 2.5 hours of sample collection, and the lab is accessible from 7 a.m. to 9 p.m.
I do here a foot scan, and the foot scan included 4 tests. One is 3D scanner, one is plantar pressure scanner, and the Doppler test and VPT test. In 3D scanner,
As you are gastroenterologist, I think I took liberal.
I'm glad that you're conducting this on your diabetes world day. As you probably know, the hormones are the most difficult ones to understand, and you cannot physiology behind all these things. And you might have come across this. I see a lot of patients with diabetes in this country. They do have diarrhea. Either we think it's because of medication or something else. What we call as a functional deficiency, rather than fecal elastase, is not the only factor in those patients. According to some of the factors I've seen here, the physiological function of the pancreatic enzymes is also low. If you actually see patients with giving the small dose of pancreatic enzyme replacement, the diarrhea settles. Majority of the time, you see them, you're either metformin-induced diarrhea and all those things. You can control those things. So I think that will be a good study to actually see within the South Indian population who are diabetics, who got some change in bowel habits, to actually see the deficiency, functional deficiency. So to cut down the story short, what you're trying to tell me is that can we create an artificial pancreas? Yes, if you can get all the hormones working together, you can. And as the artificial intelligence is going forward, I'm sure in the next 20 years we can replicate that.
Thank you very much.
Thank you.
Thing is, actually, we cannot replicate the human pancreas because it's a very complicated one. Just before going into topic, artificial pancreas is a fancy term. Okay. Just we need to coin a word called automated insulin delivery for diabetic patients. Automated. This is today's topic. Yeah, before going to today's topic, just introduction I'll give a basic about pancreas. You can see a pancreas in elongated structure, 15 into 4 into 2 centimeters plus or minus, at birth 10 grams, and at 20 years it reaches a peak weight around 70. By 60 years it starts regressing, and so that's about, pancreas. It's a complicated one. It has both endocrine and exocrine regions. So you can see in that area. Are you able to see? No. So mostly more than 90% is exocrine. It generates enzymes. It's pancreas is the central part of digestive system. So most of the thing is SNR, and in between 1 to 2% is filled with endocrine part. In that endocrine part, you will find alpha cells, beta cells, delta cells, all other cells. So, pancreas, exocrine, endocrine secretes, it secretes a lot of enzymes that digest carbohydrate, protein, fat, and other things. So our topic, and as I am endocrinologist, I am concerned about, I focus only on this endocrine topic. It contains alpha cells that generates glucagon. What is this glucagon? I'll tell you. And next is insulin from beta cells, amylin also from beta. So insulin by gluconeogenesis and glycogen lysis from the liver, mostly from the liver, by the action of glucagon. This glucagon generated from alpha cells of pancreas. So, when you are fasting, insulin is on baseline insulin at a lower level. That baseline insulin will distribute that glucose whenever necessary into the muscle or into adipose tissue. This is about fat state when you eat food, when you take nutrients and carbohydrates. So the plasma glucose gets the glucose from absorption and digestion of carb. In that state, in fat state, insulin is generated from the beta. Dispose the glucose from plasma into muscle adipose tissue, and it not only that insulin dispose glucose, it inhibits the glucagon. So glucagon won't act much on the liver to generate glucose. So that's in non-diabetic. Coming to our diabetic state. So this is diabetic. In diabetes, insulin is less. So the plasma glucose is maintained through from liver, glycogen lysis and gluconeogenesis. So insulin will be less in diabetic. If you give from outside insulin, that glucose will enter into tissues. But if you give outside insulin, that exogenous insulin won't act on, won't suppress that glucagon. So in diabetics, even though if you give insulin, that glucagon will be on highest level, and that glucagon generate glucose and increases plasma glucose. What about in fat state? Fat state, if you give insulin will be less if you give from outside. Glucose disposal into tissues. In diabetic, as I told you, that exogenous insulin won't act on won't act on endogenous glucagon. It won't suppress endogenous glucagon. That's a problem. So if you want to replicate any artificial pancreas, we should have both insulin and also glucagon. Not insulin alone can mimic human pancreas. Even study showed if you give even insulin and glucagon, body's glucose homeostasis won't be maintained at ideal range. It needs amylin and other hormones. So finally, glucose homeostasis is not only on insulin, it's a interplay of multiple hormones, not only insulin and glucagon. A lot of hormones will act, GLPs and other things will act. So with this introduction on pancreas, I want to go to next topic on automated insulin delivery. Today's topic on insulin pump, the latest model. So over to the Sumida.
For enriching session to begin with and boosting the morale of the our audience. Now I would like to start with the introduction, which our Dr. Preeti will come and tell about the few lines about introduction of this CME.
Good evening everyone. This is Dr. Preeti from AED Hospital. I welcome you all the Diab conference at the AED Hospital. Firstly, I would like to thank the experts for taking their precious time out on making to this event. About AED and the services available here, I would like to say about few things. At AED hospital, we have comprehensive emergency diabetic care, including insulin pump management, advanced food and podiatry care, foot surgeries, insoles, footwear, and inserts for diabetic.
a challenge in executing diabetics management and are definitely new to insulin pump therapy. So what we could change that? What if we could flip the pyramid and see that a more wider range of people are suitable for insulin pump therapy? So why pumps are better? An insulin pump is a device that delivers continuous and customized rapid acting insulin throughout 24 hours a day, depending upon the body's need. It delivers insulin in two ways, the basal or the background insulin and the bolus or the mealtime insulin. The basal or background insulin replaces the long-acting insulin. Here, a continuous insulin is delivered throughout the day. It covers the hepatic glucose production, maintains glycemic stability in fasting state, automatically delivers precise programmed dose, while the bolus or the mealtime insulin covers food intake and corrects high blood glucose levels. The pump also uses the bolus wizard calculator and calculate the insulin boluses and also track active insulin. So who are the candidates of an insulin pump? In general, the insulin pump is recommended for children who are unable to reach the HbA1c target level, recurrent hypoglycemia and hyperglycemia unawareness, severe glycemic variability. But this pump also proves beneficial in cases of dawn phenomena, fear of hypoglycemia, nighttime hypoglycemia, hypoglycemic unawareness, needle phobia, low insulin dose requirement, stress on the whole family, and inability to self-inject. Advances in diabetic technology and management has literally given a new life to patients living with diabetes. Medtronic for more than 40 years has been in the forefront of innovation that are transforming patients' care, diabetic management and lives. While the first insulin pump was introduced in the 1960s by a Los Angeles physician by the name Arnold Kadej, were revolutionary in their time. But with the introduction of Minimed 502 in the year 1933 enabled a more simpler and a discrete level. From here on, the pump, there was innovations leading to a more sophisticated, more tool and usable friendly pumps. Now, with the introduction of the Minimed 780G, diabetes management has taken a greater leap with the hybrid closed loop system, the SmartGuard automation to suspend before low, automated basal insulin delivery. Along with it, it allows for a more front loading of meal insulin and earlier delivery of correction post meals. This system also detects sensor or infusion set failure. So how does this pump, this whole thing work? So the Minimed 780G pump connects with an AccuCheck guideline meter. From here, the blood glucose are transferred automatically into the pump. Up to 4 AccuCheck glucometer, AccuCheck guide link meters can be connected. Next, the pump connects with a Guardian Link transmitter, which allows the use of the sensor. These two are connected with a wireless connection. Only one transmitter can be connected. The Minimed mobile app allows you to see the data on the pump and the sensor more easily and discreetly. From here, the data is transferred to a CareLink server and to your healthcare professional. You can also see the data on the computer with the help of a CareLink USB and a CareLink uploader. Looking into the pump 780G, the pump buttons, basically you have the center select button which leads you to the main menu and also to select the highlighted option. Then you have the scroll up and down, left and right button. On the right top end, you have the graph button which helps you see the graph of the glucometer and how it is tracked throughout. And then the back button to go back to the home screen or the main menu. Here the menu screen helps you to see the various functions and features of the pump. Here you have the history and the graph, the smart card, sound and vibration, reservoir and set, insulin, blood glucose, status, pair device, and setting features. This pump works on both manual and smart card mode. The manual mode is a traditional way. The basal weights are pre-programmed. Boluses can be done with bolus wizard or with manual boluses. may be used with or without a CGM. Whereas in the smart guard mode, it is controlled by a smart guard algorithm that self-adjusts basal insulin based on the sensor glucose reading. Basal insulin is automatically delivered every 5 minutes. May deliver a bolus automatically if the smart guard feature determines that a correction bolus is necessary. Bolusing before meal using the bolus wizard is necessary. CGM is required here. So the pump delivery system consists of the infusion set. It's a thin plastic tube with a soft cannula or a needle at the end inserted just underneath the skin. The reservoir is similar to a regular syringe, holds up to 300 units of insulin. And the pump, which is a small computerized battery operated device, which allows the user to control how much the insulin is delivered. The infusion set is the link between the insulin pump and the body. It needs to be changed every 2 to 3 days. So what are the benefits of this continuous subcutaneous insulin infusion? Practically, because of various basal and bolus type, there are multiple program features on the pump. It affords greater freedom with mealtime and snack, spontaneity, and lifestyle flexibility. If you see, the number of injections is reduced, at least 12 injections per month with the continuous subcutaneous insulin infusion were compared to a multiple dose insulin, which is around 120 injections per month. And clinically, there is reduction in hypoglycemia, HbA1c level, blood glucose variability, insulin doses, and also reduction in the risk of microvascular complications. And there's also improvement in metabolic control, satisfaction with therapy, quality of life, and well-being. But definitely there are some indications and limitations for this pump. This pump is approved for patients with type 1 diabetes, age 7 years and older. The smart guard feature cannot be used for people who require less than 8 units or more than 250 units of total daily dosing. The pump has not been studied in pregnant women, persons with type 2 diabetes, or in person using other anti-glycemic therapies. Use of clinical judgment is always recommended in cases where the patient cannot read instructions on the pump, refuses to check routinely your glucose, and are unwilling to announce meals before eating. So let's go into the demo of the pump. So the requirements here are the Minimed Quickset insertion device, the Minimed Quickset infusion set, a reservoir, insulin, and then alcohol swab. The areas recommended for insulin insertion, the insertion of the insulin pump are the abdomen, thigh, buttocks, and back of the hand. So filling the reservoir here. So this is a reservoir. It basically has 3 parts. So it consists of a transfer guard, which allows you, which allows transfers insulin from the insulin vial into the barrel. Then we have an O-ring, which allows, which prevents the leakage of insulin from the reservoir. Then we have a plunger rod, which helps to load the reservoir with the pump. To insert it, holding the reservoir at the transfer guard, we put it on the insulin vial and then press it down. Keeping the insulin vial upright, we pull the plunger so that the insulin is filled into the reservoir barrel. If there are any air bubbles, we just need to tap at the reservoir so that the air bubbles have gone up into the reservoir and are then transferred into the vial. Once the reservoir is filled with insulin, we need to hold at the transfer guard, turn the reservoir anti-clockwise and disconnect it from the transfer guard. Then we need to unscrew the plunger rod which is there and so keep it separately. Now we have a filled reservoir here. Next, we're going to place the reservoir into the pump. In the pump, there's a setting, reservoir and set settings, where you're going to insert the reservoir into it, and then you see that the tube connector is aligned with the groove on the battery cap. Then with the help of the filling the reservoir, we click on it. Then we need to fill the tubing here. With the highlighted or fill tubing already automatically set in there, we fill the tube till we see a drop of insulin at the end of the needle inserter. Coming to the infusion set, it is made up of the tube connected at one end, and then we have the blue handle, we have a side connector, paper packing, needle guard, a needle introducer which holds a cannula, and then we have the inserter which has an inner groove. They have two side buttons. It has a groove for the tubing, and then we have the handle which allows you to insert, and then a press release button. So if you're going to, how are we going to load the infusion set? So holding the infusion set at the blue handle, we're going to insert it into the barrel of the inserter, and see that the handle or the tubing is in the tubing connector. Then we remove the paper packing here. Paper packing here, and then we pull the handle so that with a click sound, so that the insulin the infusion set is inserted. Then we remove the needle cap here. Then the area to be prepped where we're going to place the insertion here, it needs to be prepped with an alcohol swab. Then we're going to place it flat on the abdomen, and click on the two side buttons. We're going to insert it. So I'll just show you here. Allow it. Bill. Insulin subcutaneously, and the needle need not be placed there. So this is how we're going to do. But yes, definitely there are few. Before filling the tube with insulin, the insulin vial has to be kept in room temperature to avoid any air bubbles in it. Thank you.
I'm going to talk about CGMS and SmartGuard AI enabled. So, yeah, this is the 780G millimeter. Right. So, my agenda is today to look to talk about CGMS sensors. The first one is the outlook. Next, planting a sensor, which is a demo. AI enabling SmartGuard technology algorithm, which explains how the SmartGuard technology works on the basis of algorithm, and the closing recap. Next is CGMS definition. As we all know, as the name is suggesting, it's continuous glucose monitoring system, which measures the glucose levels at very regular intervals, almost every 5 minutes, and translates these readings into easy to read data and insights. It can also show the direction where your glucose is heading and how fast. CGM systems they also are basically important in translating your glycemic readings into dynamic data so that you are able to manage your diabetes treatment. So today we are going to talk about the 780G Minimed system, which is a next generation closed loop insulin pump system for the treatment of especially type 1 diabetes aged 7 to 80 years. So this is the picture which is showing in a very pictograph showing the both the sensor and the receiver. So CGM has basically 3 parts. The first one, as you can see, the sensor, which is a glucose oxidase based sensor that is inserted under your skin and or anywhere, belly or arm or buttocks. There is sticky patch that helps you to stay there, and these sensors are called disposable sensors. There is also another type of CGM sensor, which is an implantable sensor. And the second part of the CGM is a transmitter. As you can see the CGM transmitter on the picture. The transmitter sends the information without using by wireless technologies, usually Bluetooth, to third part is software program. This software program is there either in the insulin pump or in a phone, a smartphone, which is enabled to handle this data. And this is this. Then talking about the types of CGMs, currently we have 2 types of CGM systems that are available. One is real-time CGM system and the other one is intermittently scanned continuous glucose monitoring. Real-time CGM is the glucose value minute, but the stored value is only every 15 minutes. And this needs to be again scanned by a separate receiver or data reader or a phone, and then it can be showed on the device display. The scans have to be performed at least every 8 hours to retain the whole daily glycemic data. Scanned glucose values of IC CGM systems can be either downloaded or uploaded to a cloud-based system. Yeah, this is what it looks like. The first one is the intermittently scanned. So the first one is the intermittent, first picture is showing the intermittently scanned CGM system, and the second one, which we are discussing now, the 780G Minimed pump system. This is what it looks like with the Guardian Guardian transmitter. The first one is the sensor, the second one is the Guardian transmitter, and the third one is the phone, which is a smartphone, which is and yeah, other differences between CGM models include whether whether the sensor is placed on the skin or it is implanted, or how often the sensor has to be replaced, and how long it takes to the CGM to warm up, how you adjust the program settings. And of course, calibration is one thing. For each of the CGM models, some require calibration and others don't. Next is we're talking about the monitoring part. Basically, CGMs record your glycemic glucose values at every point of time 24/7, whether you're showering, working, or doing any kind of activity. And many CGMs work with apps that have special features, so you can track all your food intake, your drug, whatever medication you are taking, and your physical activity, and what is happening at that point of time, and of course review it and take the appropriate measures by the patient himself or even and the healthcare provider. The ability to download the data onto a computer or smart device, so you can easily see the trends in your glucose levels. Basically, the whole point of monitoring is about reducing the glycemic variability, which is very inherent with diabetic patients, both type 1 and type 2. So reducing the glycemic variability is what is the most important target, which can help in achieving the desirable HbA1c for these patients. And talking about the alarms, alarm is the most is the safety feature for all of these pumps, which is going for this CGMS sensor system, where it goes off whenever the sugar level is too high or too low. And yeah, often it helps the caregiver or the parent or the partner, whoever is with them, to take the appropriate measures and avoid the catastrophe if at all is there. And next we are talking about the pros. So compared with a standard glucose meter, basically, as I told you, CGMS can help in reducing glycemic variability and better manage your glucose levels every day. Basically, because you have a very rapid measure glucose data that is coming up every minute, every 5 minutes, or every 5 to 10 minutes onto your screens. So the patient can avoid all kinds of blood glucose emergencies, whether it's I display a graphic that shows whether your glucose level is rising or dropping. So yes, we also have a Smart Guard suspend event associated with the CGMS system, and this whether suspend on low or suspend before low is the feature that is used for each of these patients according to the requirement. And this is one of the graphs that is for this is the graph we usually see for a patient for whom CGMS is installed, and this is how we look at the data. So each state's data is in different colors and showing the glycemic variability at what point, what is high, when it is high, when it is low, the timing, and all of that to be very useful. Yeah, this is the recap for all the. So this is basically a EC painless application, CGMS system, and small discrete variable and real-time numbers and alerts. So these are the sensors that are available right now in the currently available in the market with about Freestyle Libre and Medtronic Guardian Sensor 3 and Guardian Connect. These are the three CGMS systems that are available in India, with rest of them Dexcom G5 and G6, and Sensonics Eversense are available outside India. So as you can see, the duration for each of these CGMS systems is different. It is about 14 days for Abbott Freestyle Libre, for 1 week for Dexcom G5, Guardian Sensor 3 and Guardian Connect, whereas it's almost 180 days in Europe for Sensonics Eversense and 90 days in USA. And the calibration is whether it is required or not is also varying for each of them. And the age group that you can use is more than 18 years and older for Abbott Freestyle Libre, more than 2 years older for both Dexcom CGMS systems, and Medtronic Guardian Sensor 3 can be used for more than 7 years and older. Yeah, this is the AI-enabled insulin pump components. As we can see, there is a sensor that is the insulin pump 780G Minimed system. And this is the serter that is used to implant that sensor. So these are the various additional components that are required for the implantation. The tapes as well as the Guardian 4 transmitter, which needs to be charged all the time so that it can be used for the next 7 days for the to store that data from the sensor and transmit it to the phone as well as to the CareLink software. Yeah, this is a serter that is used to load the sensor. As you can see, so we put the sensor onto the ground, and then we put the serter onto it and load the serter in this way and then implant it. Demo. బ్రెయిన్ పని చేయట్లేదు. ఏమైంది? వచ్చిందిలే. ఓకే. So yeah. So after loading the serter with the sensor, we can implant this onto the arm or onto the belly. So that's how the whole closed loop hybrid loop system is being displayed now, with the insulin pump on one side and the Guardian transmitter with the sensor on the other side, and both being in association. Thank you. So this as the sensor After implanting the sensor, it takes about 2 hours for the warming up session, and as the sensor starts displaying the sugar levels onto the screen of the insulin pump and also the smartphone of the patient. So as you can see, the smart guard shield. You can take the patient disclaimer. Thank you. So as you can see, the smart guard has come into play. It takes about 48 hours after it takes about 2 hours for the sensor to warm up and then the sugars to be displayed. Another 48 hours, until which there is a by manual mode we need to continuously operate the pump, give boluses and decide the basal insulin rate. And as you can see, the smart guard is the shield one, which is showing that the smart guard has come into play. So as I told, it takes about 48 hours for that to come onto that screen, and the center value is the sensor glucose value which is being displayed there. And the active insulin is the right hand down corner part, which is showing how much insulin is being given at that point of time, real time. Then so each day and night insulin needs basically vary for the patients according to the activity at that point of time, what they are eating, and various other challenges which can come into play deciding the dose of the insulin. So if at all they are the correction boluses for high glucose levels are a common cause of hypoglycemia, forcing recovery curves for the treatment. This part is going to be avoided by Minimed 780 system once it goes into the artificial intelligence. Smart guard technology comes into play with auto correction boluses coming up early, and therefore the amount of insulin that is being given to the patient and the recovery carbs that will have to be given, if at all it is being given manually, this is all going to be avoided, and that's how the patient's life is going to become easier and maintain the sugar levels within the normal range. So this is the slide that's showing smart guard, how that works. So basically, by the pump, with the help of the sensor, CGMS sensor, sugar readings, basal insulin is delivered every 5 minutes based on the sensor glucose readings. And the basic aim is to keep the patient's sugar levels between 70 to 180 milligrams per deciliter. And manual mode basal rates or the maximum basal setting does not affect the auto basal delivery. We also have the other one, temporary target, which will be used if at all the patient is going into very intense physical activity. Then the temporary target feature is being switched on, and usually the target glucose range in the temporary target is temporary target mode is 150 milligrams per deciliter. So because there's less amount of insulin desired, the amount of the boluses, the automatic boluses are being switched off in here because of the switching on of the temporary target. So this is a pictograph of the very basal insulin with the basal correction dose that is being given according to the sugar levels of the patient. Auto correction bolus. This is apart from the basal, you also have boluses being delivered whenever the serum glucose levels are more than 120 milligram per deciliter. Of course, the auto correction feature needs to be switched on, and this can be delivered every 5 minutes. And all the auto correction boluses count towards active insulin totals. So this is the algorithm based on which the smart guard technology works. So as you can see, it's PID, the proportional, integral and derivative. This uses real-time info of current serum glucose. Proportional means how far SG is from the set target. Integral shows integral is about how long SG has been away from the target, and derivative how rapidly SG has been changing an estimated total insulin, including both basal and bolus. So this is the whole algorithm and the whole point on which AI technology, smart guard technology is working and helping to give automatic boluses as well as basal insulin to the patient and maintaining the sugars within the normal range or the target range we are trying to achieve. As I told you, there's auto-basal and auto-correction boluses. This is what we are seeing. The blue lines, the vertical blue lines are the auto-correction boluses, and the pink, the basal as well as the auto-correction basal doses. Yeah, this is the time in range. This is the one we are trying to target and achieve for every patient who is being for whom Minimed system is being used. As you can see, the time in range should be at least more than 75%. That is the target, and below range and high range should be very minimal, so that we achieve the desirable HbA1c at the end of the period, whatever we are targeting. So as we can see, time in range is low, time above range is high, time below range is high. So these are the various glycemic variabilities that can be encountered during this time when we are targeting the time in range. When time in range is low or high, it needs a lot of adjustment. For when it is low, when time in range is low, pre-meal bolusing needs to be corrected and checked and change the insulin carb ratio. This whole boluses and the insulin carb ratio is what that needs to be adjusted according to the time in range feature, whether it is high or low. And yeah, this is the overview, closing recap, which is talking about time in the advanced glucose management delivered by Minimed 780G system. The time in range goal more than 75%. Blood glucose target is about 100 milligrams per deciliter both night and day. Average time in Smart Guard feature goal is 85%, and auto correction boluses is up to 12 times per hour. And this Minimed 780G system is waterproof, and alerts to care partners is there for us to alarm the care provider or the partner about what is going on in the real-time glucose feedback. Thank you.
What a wonderful session. And now we would like to announce the testimonial by our own AED patient, Mr. Pavan Kumar, who will share his experience with the pump and how he could manage to control ketoacidosis also.
Thank you. Good evening all. This is Pavan Kumar. And I am working in the software company as a developer. And previous few weeks, I am struggling about increasing the ketos and DKA. So last week I admitted, I stay in the KBHP colony only. So nearby hostel, my one doctor is there. So he recommended this hospital. And after that I admitted, I came here and checked with the Manoj sir first. And after that I checked with the guidance of the Dr. Ravi sir and Rajita madam. My sugar levels are 650 to 700. It is more high. So after that I admitted in the hospital. So they treat me as like a son, and they put the pump in the first day only. And first time I am admitted in the hospital whenever I didn't get any disease also. So after that I admitted in the first day. I tensioned it was decreased or not. So after 4 days, when they put the pump and giving the food recommendation with the diet specialist Deepika and all the persons, and now I decreased the weight till 15 kgs. So now within 4 days I increased to 2 to 3 kgs. So recently I discharged, and now I am going to office also. So because of this pump and all the doctors.
Thank you so much. And now we will conclude with 2 more sessions the foot examination, complete foot analysis, which is being done in AD hospital. So for elaborating on the same, I would like to call upon the stage Ms. Himani. Please welcome.
So good evening everyone. I am Dr. Himani Umale, an orthotist, and we all know about the foot in diabetes, how the foot get affected due to diabetes. So I am going to present today foot examination in AED hospital. So there is a 4 tests we do in AED hospital. First is 3D scan. It is a 3-dimensional analysis of the feet. So 3D scanner is a device that let us determine the degree of eversion, inversion of the foot and flat foot or callus and their severity in confirming the exact location of corn, callus, ulcer, etc. and take the measures accordingly. Then the next test is plantar pressure scanner. It assessment of the foot pressure distribution. A plantar pressure scanner helps to know how much pressure is falling on which area of the foot while a person is either walking or standing. We also can find our followings like maximum pressure, mean pressure, stabilometry, static analysis and dynamic analysis. Next is Doppler test. Doppler test is used to detect the blood flow. It shows whether a pulse is present and whether there is blood flow to a limb. It can diagnose or help to manage conditions such as peripheral arterial disease or diabetic foot ulcer. Compare blood pressure measurement in your ankle and arm. If blood pressure in your ankle is lower than in your arm, you may have reduced blood flow to your feet. This is called as ankle brachial index. So we use the Doppler machine and BP machine to perform this test. Next is a monofilament test. Patient will close the eyes while the orthotist brushes a soft strain on the toes and patient tell the orthotist whether he feel the strain touching in his feet. We can see that picture of the filament and the fit. Next is vibration perception threshold test. Is orthotist will place a tuning fork or other device that vibrates on the different part of the foot. Different parts mean there is a 6 points in the feet. We put the vibrator on the feet and toes to see if you can feel, if the patient can feel the vibration. We can see the second picture, the vibrator machine and the feet. These are the report. First report is monofilament and VPT report and second report is Doppler test report. Next, assessment by the orthotist. Orthotist will check the patient's feet manually, posture analysis foot skin problem, ulcer, corn and callus. So according to the patient detail analysis, we prescribe the foot orthotic recommendation like footwear, prefabricated insoles and orthotic inserts. You can see the insoles. The first one in the black and orange is the standard diabetic insole which relieve the pressure from the feet. And the second one is a pour-on one which have a little bit arch support for the flat feet who having a flat feet and like a little bit pressure relief also. And we can see the insert. For the bunion deformity, we give the bunion splint, and for the plantar fasciitis, we give the silicone heel pads. There are other inserts and insoles also for the different kind of deformities and problems. So next is footwear. These kind of footwear is the diabetic footwear we provide. We also provide the offloading shoes for those who having an ulcer or corn or callus. Thank you.
So our last session, the concluding session will be conducted by Dr. Musi on newer anti-diabetic drugs. Please welcome Dr. Musi. And after that, Dr. Ravi sir will come. Thank you.
Hello, good evening everyone. This is the last topic of the today. So there are the latest options available for treatment of diabetes. So as we know, the insulins are based on the duration of action. They are divided into bolus insulins and basal insulins. So under bolus insulins, we get the rapid acting insulins, short acting insulins, and very rapid acting insulins. Under the long acting insulins, bolus insulins, we get intermediate acting insulins and the long acting insulins, which is given once a day. So if you see, recently there is a very rapid acting Lispro has been launched, insulin, which is a very flexible type of insulin, which can be taken just 2 minutes prior to the meal and can be taken up to 20 minutes of the after taking a meal. So it is very flexible in taking the insulin, because most of the patients will be having multiple time restrictions, because if they want to take the insulin, they have to take prior at least 15 to 20 minutes and wait, then take the meal. So with this insulin, they can just take 2 minutes prior to the food and can be taken 20 minutes after the meal also. So generally these short acting insulins will work maximum of 4 hours, but this ultra rapid acting Lispro, it works almost 6 hours postprandial. So it reduces the post glycemic excursions up to 6 hours than the previous group of drugs, which controls only for 4 hours. So in this way, this is way beyond good, that helps in controlling the blood sugar levels. So as I already discussed about the basal insulins, generally as of now we have basal insulins which works 24 hours in a day and maximum of 32 hours in a day. So those drugs are already available in India. The names are Degludec and Glargine U300. So these acts maximum of 24 hours to 32 hours. But if you see, there are trials that are going on one of the basal insulin known as Icodec. So this insulin can be taken only once in a week. So this have very long shelf life and very long duration of action. So if you take once in a week, this will control the post-prandial hyperglycemias and the fasting blood glucose. So in this way, it helps type 1 diabetic patients especially, and reduces the number of insulin pricks in a day. So as we already known, there are two type of incretin hormones, that is GLP-1 and GIP-1. So we already know GLP-1 analogs are available in the form of injectables, because these are peptide hormones. So generally when they are taken orally, so they break down and the action is not going to happen. So what happened in the last few years back, the oral semaglutide has been launched, which is one of the peptide GLP-1 agonist only, but they have used snack protein, which prevents the breakdown of this peptide protein over it and helps in absorption. So generally these only GLP-1 analogs are available. So in recent updates, and there are multiple trials that are going on. So there are dual incretin agonist is coming, that is both GLP-1 GLP, so which is going to come into India in coming future, and the drug is known as terzepatide. So it blocks both GLP-1 and GLP both agonists. So as we already discussed, both GLP and GLP, along with the insulin, glucagon is also very important for the glucohomeostasis in the body. So to cater that benefit also, there are studies that are going on where GLP, GIP and even glucagon agonists are also coming. The drug is known as retatrutide, which is expected to come in coming future. So as I already discussed, these all GLP and GIP are peptide hormones. That's why they are available only in the form of injectable forms. So to prevent that, there are studies that are going on where oral GLP non-peptide receptor agonist drugs are also coming into the studies, where we can expect that also injectable form where now is available, which can be expected in the form of oral also. So like metformin, how we use regularly, there is a drug called imiglamin, These drugs are not FDA approved, but they are still used in many of the countries. This acts similarly like the metformin. It comes in 500 milligrams. It can be given as twice daily for a type 2 diabetic patients. So what it does is like similar to the mechanism of action of metformin, where it reduces the glucose output from the liver, and it increases the glucose uptake from the muscles, fat, etc. So our India is where fixed dose combinations are present. It is not available in anywhere outside India, where multiple drugs like glimepiride, metformin, and DPP4 inhibitors and SGLT2 inhibitors are combined in fixed doses. Like if you take an example where glimepiride 1 mg plus metformin 1000 mg and SGLT2 inhibitors like dapagliflozin 10 mg is given as a single pill. So this reduces the pill burden for the type 2 diabetic patients. So this fixed dose combinations is available only in India. So this is one of the advantages where it reduces the number of pills for the type 2 diabetic patients. So thank you. And after this, Ravi sir will move on with the vote of thanks. Thank you.
So for vote of thanks, I would like to welcome Dr. Ravi Mupidi sir on the stage.
Ladies and gentlemen, ladies and gentlemen, good evening. I extend my heartfelt gratitude for everyone, each and everyone, for coming here and making this event, this CME, a great success. Please join for dinner. Thank you very much. And I also appreciate the organizing committee. And also, I'll thank the sponsors for their support in conducting this event. Thank you very much. Please join for dinner. And I want to tell some pure vegetarians. I think we'll keep one bench. Pure vegetarians, give this bench. Hmm? Okay. Please join for dinner and thank you.
Hey, player one, do you think you're ready for this? Join Valorant and play.
Yeah, latest treatment options. Rhythm. Smart guard functions. Create time and range.